Hello, my name is Anthony Fong. I'm the director of PT Indo Sehat Utama in Indonesia. So today's topic is about SpineCor. So whenever we talk about scoliosis, there's many different treatment options for scoliosis. So the most common method is that when you see doctors and you have scoliosis, the first thing that we'll do is what we call observation and monitor. So under these circumstances, if a patient has scoliosis, they usually advise to have an x-ray, and it usually involves a scoliogram. It could be an x-ray from the back and side view, or depending on the doctor or the hospital, they may request to have the x-rays taken in multiple sections. And this may also involve the patient bending to the side or lying down or standing. So most commonly with all kinds of scoliograms or x-rays for the spine, it is most preferably done with the patient in a natural position and while standing. So when it comes to scoliosis, there's many different classifications. In the past, when it comes to scoliosis, we usually focus on scoliosis with the curve and the upper body or the lower back. Now, there are patients who have scoliosis both in the upper back and lower back, so that would be classified as a double curve. Now, there are people with 3 curves or 4 curves, and very rarely do we ever see 5 curves, which, although that been said, it has been seen once, but that also involves the neck as well, which when we're dealing with scoliosis, we're primarily more interested in the upper back and the lower back area. Now, there's also a different type of curve where your spine is a C curve. Now, then you also have different combinations of curvature. So you can have different types of curves for the spine with rotation. You may have rotation in the lower back, a counter rotation in the upper body, and in the upper thoracic as well, or in the right up in the upper thorax area. And you can have up to 5 different rotations in the spine. Now, most of the time when we deal with scoliosis, we usually deal looking at the spine from the back. However, most people don't realize that when we look at scoliosis, even from the side view, if you're hunching or if your curve in the upper body, normal curvature is normally about 37.4 degrees here, 40 degrees in the lower back. If your curve is more than 50 degrees as a child, you're classified as having hyperkyphosis or you're hunching. As an adult, there's 2 different types. If you're more than 50 degrees, it's what we call adult hyperkyphosis type 1, where you're hunching, but you're still upright. Then there's another one, which is adult hyperkyphosis type 2. This is where you're hunching, but your whole body is leaning forward. So for most patients, that would also mean that you'll be leaning quite a fair distance and translated forward. Now, when it comes to scoliosis, that was the traditional model of the spine. So most treatment techniques or guidelines are based on those following curvature. However, in 1992, there were studies being conducted in Canada by Professor Rivard and Dr. Colliard. And they're both pediatric orthopedic surgeons, and with Dr. Colliard also being a medical scientist or a scientist into biomechanics into the spine. And what they found was that one of the biggest cause of scoliosis is that we normally say that it is of idiopathic origin. And when we say the word idiopathic, it basically means we don't know how you got it, why you have it, and let alone what are the most effective methods for treating it. So different techniques were produced, such as bracing, exercises, and etc. Now in 1992, they found that it was of genetic origin. And with scoliosis, it doesn't just affect 1 or 2 components of your spine. So a lot of emphasis has been placed on trying to correct the structure. Or then you have other schools of thought, which is to address the muscular part. So different exercises were introduced to try and strengthen the spine. Or in some cases, rehabilitation techniques, such as trying to stimulate your balance, or what they call vestibular ocular reflexes. But one thing they found with studies is that when it comes to scoliosis, it is not one component more exclusive than the other. It is a pathology of all 3 components. So if you do have scoliosis, it does affect your bones, your muscles, and your nerve all at the same time. So when it comes to treating the spine, you cannot just treat one component separate from the others. All 3 components must be addressed at the same time. during the same treatment. So this is where the limitations of current braces come in. So with the current brace, it was based on that few classifications that we just mentioned. Now, one thing is that in 1992, when they conducted studies, they found that with adults, there's 12 different types of classification. And for children, there is 27 different types, which means that when it comes to treating scoliosis, you have to be very specific with what type of scoliosis you're dealing with. So a person may present with a double curve. And so the treatment that you use for a double curve cannot be the same for every other patient with a double curve. Because the patient may have, or the person presenting may present with a double curve where the primary source is the upper body. And the lower back becomes a compensatory curve, or that's a compensation. Now, other patients may have a primary curve in the lower back area, in the lumbar area, and the upper body is compensating. So if you were going to use different types of exercise techniques, there are different exercise methods out there, which only uses 7 classification of the spine. That becomes very, very limited, considering that there are 27 different types for children, and as we mentioned before, 12 different types for adults. So you cannot use a generalized double curve exercise on every single patient, because you need to first of all identify where is the primary source, where's the compensation, and the treatment technique or the management technique has to be targeted and very, very specific in dealing with what type of curve you have and the different types of biomechanical changes. So with hard brace was introduced, and it has been used for many, many years. So in the upper body, we have 12 bones. In the lower back, we have 5 bones. So traditionally, the upper body here, we call it thoracic. So the bones are classified as T1 to T12, meaning thoracic bone number 1, number 2, number 3, and so forth. Now, when we look at scoliosis, we usually look at what we call the apex, where the bone is the most horizontal and the most laterally displaced, which means the bone that is the most shifted to the side. It could be the most shifted to the left side or right side, and it could be any one of the spinal bones here. So when it came to traditional hard braces, if the bone in the upper body, the apex, was from T7 below, braces such as the Boston brace was used, or rigid braces very similar to Chanel brace or the Ginseng brace. So there's many different hard braces which were used. And if the curve was quite high, anything more than T7, a Milwaukee brace was used. Now, there are different types of hybrid braces out there, and in most cases, it will address one or the other, or it will be concentrated or focused in one area, but it might not work on the other. Or in some cases where a person may have a double thoracic curve. So in this case, you have 2 curves in this upper body here. Then those traditional hard braces may become limited in its application, because now you have 2 apices. You have one apex in the upper thoracic area between number 1 and number 7. And so it will be number 6 and 7 or 7. And then the other one is you may have an apex between T7 all the way down to T12. And it can be T12, T12 L1 or L1. So in this case here, you have 2 curves in the upper body. So you can't really combine a Boston and a Milwaukee simultaneously unless you're very creative and very skilled in your prosthetics and orthosis. So when we're dealing with the spine, this is where SpineCor has developed different techniques to address each and every single type of curve very specifically. Now, even there's also SpineCor exercise methods, which are specifically designed for each and every different types of curve and different classifications of the spine. So the most important thing is a very, very specific and targeted management or treatment technique for scoliosis. And this also depends on the age of the patient, the sort of severity of the spine, the magnitude of the curve, and in other cases, also what sort of symptoms or the objective of the patient. So if the patient came in with a curve and they're a child and they haven't had their menses yet or they're prepubescent, then the number one objective is to try and correct the spine as much as you can before they hit the growth spurt. If the patient is already going through a growth spurt, in most cases, your main objective would be to either try and slow it down, stabilize it or provide support. In some cases, we co-manage the cases with orthopedic surgeons. The curve may be quite large, and in this case here, we will work with the surgeons to try and at least either try and keep the spine stable before they have surgery. So the brace may be used as a pre-operative device, a supportive device in this case. So it is more to either slow down the spine or provide support before they have surgery. So in terms of the effectiveness of this, when it comes to the spine, the main objective of the spine is to allow flexion and distraction and every different movement. So in this case here, when we're dealing with the spine here, the traditional model of using the rigid brace is if you are bent to one side, the rigid brace was designed to try and straighten you out. So if you had a bend to the side, leaning forward, and you were rotated, then the rigid brace will be designed to try and unbend you, straighten you out, and untilt. So in this case here, they use what we call 3-point pressure. And the idea behind it was that if your spine was tilted, so the idea behind it is if your spine was tilted to one side, then the best method to address this is to straighten it out and immobilize that structure. So with most rigid braces, the recommendation is to wear the brace 23 hours a day. Now, studies have actually shown that removing the pressure off a bone does not stimulate bone growth. So just because you've taken pressure off that spine, it doesn't mean the side that has been compressed will catch up. So what they found was that this is applying through Wolff's law and the piezoelectric effect, is that if that bone has been compressed, studies actually show that bones that is compressed can either slow down or in some cases stop that bone from growing. So if that child was going through puberty and there was a lot of pressure on that side of the spine, then that side of the spine, if this is the primary source, it actually stops growing. So straightening it out does not magically make it grow back. So the studies actually show that in order to stimulate that bone growth, there has to be compression and distraction. And this has to be repeated at least thousands of times during the day. So there has to be opening, closing, compression, and stretching of the joint simultaneously. A rigid brace does not allow you to do that because your spine is immobilized. Whereas in the case of the SpineCor brace, it allows this movement, opening, closing. It also puts your body into what we call a corrective position and allow movement while providing resistance and strengthening of the spine, stimulation of the bone, and allow proper biomechanics. So the difference with the SpineCor brace is that it addresses all those three components that we measured at the same time, whilst allowing flexibility, movement, and the good thing is it's discrete, which also helps improve compliance. One of the biggest issues we have is that with any kind of treatment or brace, it only works if the child or the patient is compliant with it. So you may have the best treatment in the world, the best medication in the world, but if the patient doesn't use it, then you've rendered the treatment ineffective. At least with the SpineCor brace, it's discrete. This can be worn under your clothing and people can't see it. Or in most cases, it is not that obvious. Now, we do have lots of clients who wear this. They do things like hip hop competitions, they play tennis, badminton, ballet, they play sports. So this does not restrict you in any way. So this allows a lot of independence in that sense. Okay, now, when it comes to the SpineCor brace, how effective is this? Now, in 2007, in the Journal of Pediatric Orthopedics, there was comparison between the SpineCor brace and other types of rigid brace like the Boston brace or the thoracolumbar sacral orthosis, or what we call TLSO braces. What was actually quite surprising was that they found that those rigid braces were found to be only 15% effective, and 79% of those patients ended up having surgery. And in this case here, they were only effective in stopping 21% from surgery. The other 79 went on. And one of the biggest issues that was a concern was the fact that if this spine was immobilized for 23 hours a day, the muscle tone, the strength, the core stability may be compromised or it becomes weaker. So the idea is that during that 1 hour of the day, you are supposed to do exercises. Now, however, the only issue is this person has been immobilized for 23 hours a day, every single day. So as time goes by, the muscles become weaker and the support structure gets affected. And in the case of most clients, they actually find that as time goes by, they get lazier and they need to lean into the brace. So from being able to hold themselves up, they now start leaning into the brace to support themselves. So the more they lean into the brace, the more the muscles become weaker, and as time goes by, it may even lead to disuse atrophy, or in some cases, during our conversations with a lot of the rehabilitation specialists, they do mention that the muscle tone, the strength appears to be affected as well. Now, in the case of SpineCor, because there's a lot of resistance in here, these are all strong, very elastic, resistant bands. And this allows not only the corrective movement, but freedom of movement whilst allowing resistance. So this person will be performing at least over 10,000 moves in a day, with opening, closing, compressing, stretching the joint, whilst at the same time strengthening and fighting all of these bands here, which also works on resistance training, which also helps with the bones. And then they're also in the corrective movement, which allows proper biomechanics of the spine. Now, in this case here, what they found with SpineCor brace was that it was found to be 3.9 times more effective than a rigid brace that was tested during that clinical trial. And it was also found to be 3.7 times more successful in stopping the surgery compared to other different rigid braces. Now, that is not to say that SpineCor is 100% guaranteed to stop the surgery. But when you compare it to those braces which were tested, such as the Providence brace or the Boston brace, it was found to be almost 4 times more effective than those braces in either halting the surgery, delaying the surgery. But of course, as with every single case, if your curve deteriorates or it continues to further progress, this is why we work very closely with spinal doctors and spinal surgeons, because in some cases, despite all your best intentions, if the spine is going to continue becoming aggressive, then surgery may be the most viable option. And as a matter of fact, in this case, we tend to reject more cases than we accept, because you have to be prudent and vigilant in the cases that you deal with. So it is not to say that every single patient that walks through the door gets a brace. In most cases, we first of all have to assess you to see, are you suitable for wearing this brace? Is this brace suitable for you? And does it meet your expectations, and what is the objective? So if you are an adult and you're coming in hoping that your spine can straighten up, the answer is it is not the objective of the brace. If you're an adult, the main objective is pain management, to provide structural support, spinal stability, and in this case here, also allows some freedom of movement. And in some cases, do we see patients' posture improving the curve? Yes, it do. But is that what we expect all the time? That is not the objective. So our objective is to at least try and restore back balance. So this is what we call coronal balance. So where if this is the midline here and your spine is shifted to the side, that's called coronal balance. So the main objective of bracing adults is to try and restore back the sideways balance, and also from the side view, what we call sagittal balance, balance to the front, balance to the back. So in this case here, we try and maintain a neutral balance or try and achieve it as much as possible. And this will usually allow offloading of the spine and prevent further back pain or management techniques. Now, for children, on the other hand, as we mentioned, the objective is before puberty to try and correct the spine as much as possible. But if they're going through puberty, our main objective would be either to slow it down or to try and keep it stable or to try and support it as much as possible. Now, there has been other clinical studies which also found that with SpineCor, it was tested in over 72 different countries. And what they found was that it was tested on over 400 patients over a 10-year period. And clinically, it has been found to be 89% effective. So that is actually quite a large clinical trial. So you can imagine some clinical trials usually involve 20 even 50, 100 patients. This is 400 patients. Most clinical trials are usually conducted over 6 months, 1 or 2 year period, but this was over a 10-year period, and it was found to be 89% effective. Have you ever seen a SpineCor brace? This is what a SpineCor brace looks like. This is the upper section of the SpineCor brace. So this is what we call the bolero, and this is the lower section known as the pelvic shorts. The SpineCor brace is made up of the upper, lower section, including these corrective bands over here. Did you know that SpineCor brace has been shown to be 3.9 times more effective than rigid brace, such as Boston brace? This was found in clinical studies, such as the Journal of Pediatric Orthopedics, and that was back in 2007. Did you know that SpineCor is used in over 72 different countries, and it has been tested on over 400 patients over a 10-year period and has been found to be 89% clinically effective? Do you have scoliosis? Did you know that there are many different types of scoliosis? You probably know that you either have an upper curve or a lower body curve, so what we normally call a thoracic curve or lumbar curve. Or you may have a double curve, such as an upper curve, lower back curve. Or you may have a C curve. But did you know that studies have actually shown, and in 1992, there has been shown that adults have over 12 different types of curve. And for children, there's 27 different types of curve. So which one are you? When it comes to treating scoliosis, you need to be very specific. It is not a simple task as let's just address this upper body curve, lower body curve. Did you know that there are different types of curves in the upper body? For example, you may have an upper body curve, lower body curve, but the primary source is here. Or you may have a double curve and the primary source is in the lower back. So you cannot use a generalized type of exercise or treatment technique addressing these two. You have to target the primary source specifically. So in your case, if you do have a double curve, where's your primary source? For more information, you can contact us on this number.